David, if you could introduce the rest of the team so we can sort of distribute questions to the rest of the panel.
Sure. Where is the rest of the team? Let's get them all on here. There's Ralph. Ralph is a lecturer of exercise physiology. He's in an office just around the corner from me. He's an expert exercise prescription an exercise physiologist, especially in different cancer populations and different disease populations. And then we've got Barbara Fielding, who's a reader in nutritional science, and she is a fantastic metabolic expert who knows everything about lipids and lipid metabolism. And then we've got Caitlin over here on my left, who's a dietitian who's just joined, just like myself, and Long on the right-hand side, who's also a dietitian. Caitlin has expertise in hematologic malignancies as a dietitian, and Long has expertise in treatment and different chemotherapy options for different solid tumors as well. So together, hopefully we should be able to answer all your questions.
Fantastic. Thank you very much. And thank you for all the panel to join in. So I'll start maybe from the controversial question first. And obviously the discussion hopefully involves, and I'll try my best to answer all the questions been coming in before this webinar and during that webinar. So the question about chronic fatigue syndrome. So there was recently NICE has backtracked the use of graded exercise therapy for the use of ME and chronic fatigue syndrome. David, what's your thoughts about that?
For sure, chronic fatigue syndrome and ME is such a debilitating disease, and a graded exercise protocol just will result in more fatigue and really make life much harder. And I think we've understood that now for a little while. It's just taken quite a long time, relatively speaking, for the advisory committees like the CDC and the NICE to be able to say maybe we shouldn't be doing these graded exercise protocols anymore. But exercise is still an important part of the care for chronic fatigue, because no exercise is actually worse. It just the graded part of it just means that you shouldn't be progressing to a higher intensity and a higher amount or a higher level over time. And so it's always going to be a difficult thing to be able to treat as an exercise prescription. And it's probably more likely to go to a rehabilitation or a physio than what it would to an exercise physiologist. But it's something that we have to consider in all cancer populations and in all disease populations, because fatigue is a prominent part of the side effects of cancer and the cancer treatment.
Yes, thank you. And indeed, as you said, it doesn't have to be exercise, just walking to the shop around the corner, using stairs rather than lift. I keep telling people stairs are for people in wheelchairs and suitcases, not for you. If you can do stairs, go for the stairs. Ralph, would you like to elaborate or add to what David has already said?
Yeah, no, of course, I totally agree with what David has said. And I think what you see as well is where we, as clinicians and exercise physiologists, we're sticking a lot to these graded exercise tests where you're on a bike or a treadmill till you can't exercise no more. That's good if you're working with healthy people, but if you're working with people with severe fatigue, those tests don't really say anything. So we're moving more towards functional tests. How far can you walk within 400 meters, or how quickly can you walk 400 meters? So I think exercise is, even with people with fatigue, very important, because it can work invigorating. We just need to do it carefully and not over exaggerate it too much to increase the fatigue even further.
Yes, and I think the graph what David showed quite early on in presentation, that even very small amount of physical activity is better than nothing. And you also just simply move, we are bodies, we've got hands, we've got bones to use. So I think it's important to utilize them. It doesn't matter how little. So moving on to the next question, can CLL be looked partly as a metabolic disease? Obviously, that's an area of your future investigation, David, but do you want to just start answering that?
Sure. So most cancers can be looked upon as a metabolic driven disease. There is, since we figured out how glucose is metabolized in tumor cells almost 100 years ago, we've known that metabolism changes depending on what cell type you're looking at. So for sure, CLL is a metabolic disease to some extent. There's obviously a genetic component to it as well, which is much more prominent. But the metabolism part of it is quite influential. And in the case of CLL, it's actually quite unusual compared to other tumors where the lipids and the lipoprotein metabolism is the dominant strain of energy that it utilizes. And so this is potentially a targetable component of it. We just don't know enough about what changing lipids and changing sugars will actually do to the CLL cells at the moment anyway.
Barbara, would you like to comment, add anything to what David said?
Yeah, so hi everyone. I'm really interested in the enzyme lipoprotein lipase that's upregulated in CLL. And when David first came, we were having a little chat about, what we were doing, and he started. And as soon as he mentioned LPL, my ears picked up and my eyes lit up. And, I realized we had something really in common here that we could work together. So, lipoprotein lipase, it uptake, as David said, it deals with dietary fat. So it's the triglycerides. Everyone's heard of the triglycerides in our blood. It hydrolyzes, it breaks down the fat to take up fatty acids into the cell. And we know how that's regulated in healthy people in adipose tissue, for example. So it's the way that our fat takes up fat. But what we don't know is how that's regulated nutritionally in CLL, and that's really exciting. And yeah, so that's about the metabolic pathways of fat metabolism.
Thank you. The sort of related question. Obviously, I don't know whether there's anything about, you already answered that question. If CLL store lipids and utilize free fatty acids, is there any ways through the diet to inhibit lipid metabolic pathways?
Yeah, so, David and I had a chat about that, and that's what we don't really know, because LPL is normally regulated very carefully by internal mechanisms. There are little proteins, there insulin and so on, carefully regulates lipoprotein lipase. But in CLL, it's more active all the time. So we don't really know what these, nutritional changes, what difference that would make to an enzyme that's really so highly expressed and so highly active. And that's what we really want to look at.
Mm. And obviously, do CLL feed more on fatty cells or glucose? I mean, you partially answered that question.
I think it's, from my understanding from what David's saying, is they do rely on the fat. Yeah, that's one of the sort of the features of them. Yeah, uptake of fat.
David, one of the questions was talking about ROS levels and effect of apoptosis in CLL cells. That's quite a highbrow question. So congratulations to anyone who's asking. I'm not sure I would be able to answer that one. So over to you.
Yeah, it's not even a question that I can answer in a short space of time, because it's there's so many different components going on. But there's actually quite a lot of evidence to suggest, I say a lot of it, there's evidence to suggest that higher amounts of ROS makes the cells, the CLL cells specifically, more targetable to their therapies. And so that's great. So if you've got more ROS in your CLL cells and you start taking ibrutinib or venetoclax, then perhaps those CLL cells undergo apoptosis much quicker But how do we make the ROS higher when we know that actually ROS is quite damaging to other tissues? And so it becomes really complicated when we start to think about this. Yes, high ROS might be oncogenic, but it also might stimulate better killing by targeted therapies. So how do we approach that? And I think it always comes back down to balance and the way we peak and trough on different levels. And so if you think about exercise creates an oxidative stress component, and ROS goes up and then it comes down. But the ROS is generally there to help with adaptation. The ROS in the CLL cells is always that little bit higher. And so an antioxidant in untreated or treatment naive CLL may actually cause the ROS levels to drop within the CLL cells and then promote apoptosis. So it's kind of, well, do you want it to be high if you're on therapy, or do you want it to be low if you're not on therapy? But how do we control it so that it's not damaging all the other cells, not causing a rapid progression? I personally think that it's the high ROS is great for the targeted therapies, and if you can get it down a little bit, then that's going to open up the door for self-inflicted apoptosis of the cells.
Thank you. Ralph, couple practical questions. So patients starting an exercise plan will be coming from different levels of fitness and ability. So we've got obviously Matt we listen to, but we've got the other extreme. So how should they start and how should they build up?
Well, I think the first step when you're thinking about starting exercise is have a chat with your GP or your consultant about it, just to make sure that they're aware that you're wanting to do that and that they're happy with that. Then the next step for you is to actually inform yourself, because I wouldn't recommend you just going to your local gym and say, hi, I want to start exercising, because for most of you, if you're undergoing treatment, there's a lot going on, especially with fatigue levels. There might be certain contraindications with certain medications with exercises. So when you start exercising, always find someone who is a cancer exercise specialist. So if you go to your local leisure center, you can find out if they have someone like that, or if you look online, there's a couple of institutes, for example, CAN Rehab, so Cancer Rehabilitation. That's a big organization that helps to qualify and organize cancer rehab specialists, people like myself who work with people with different cancers and different stages within their treatment. And we really work with you from an individual basis. So if I work with a client like Matt, the sessions might look much more like that you would see in a normal gym session. But if you're working with someone who's currently undergoing chemotherapy, the exercise sessions look very much different, and we then tailor it from person to person, but also from day to day. So this morning I did a session with one of my clients who just had chemo, and the only exercises we did were sat in a chair. And even for them, it was still slightly strenuous. So main advice is get sign off from your doctor, and then go and work with someone who's qualified to work with people with cancer, just to make sure that the exercise doesn't injure you or it makes the disease worse.
Okay. There's a couple more questions I want to pick up what you just said, but before we do that, I just noticed on Q&A something which sorry, David, I should have get you to clarify. What is ROS?
So ROS is reactive oxygen species, and it's a byproduct of mitochondrial metabolism. And you also have a reactive nitrile species as well. And they're just molecules that are overflow from mitochondria and can influence cell structure and cell signaling.
Yeah, thank you. Okay, so let's get back to Ralph. So what about exercise and in somebody's on treatment? How should someone on chemotherapy tackle exercise? And how should someone on oral chemotherapy like ibrutinib tackle exercise?
It really depends what your start level is. What is your fitness level? What type of exercise can you do? And that's where it comes in, working with someone who is familiar with cancer, with the different treatments, where we can, oh, sorry, my lights have gone off.
Oh, don't worry, we can hear you. You keep talking.
Lights are back on. Really work with someone who knows your situation, and then from a really personal perspective, we'll start working with you. But a lot of it also depends on what type of exercise or physical activity you prefer. It's really easy for me and David to design an amazing exercise program, but it might not be that enjoyable. And one of the main questions people ask me is, what's the best exercise for me to do? And no matter who you are, how fit you are, my answer will always be the same. Do the exercise you like to do, because that's the one you keep doing. If you like walking, walk. If you like going to the gym, go to the gym, because it's not just doing an exercise once, it's prolonged keeping up that exercise. And that's the important thing. And with that, there's millions of variations of types of exercise you could do, as long as you work within your own limits.
Yeah, I think you're absolutely right. You just, there's no point picking up something just because we're saying it's good to do. No. I think it's so important to pick up something which is simple and something you would stick with. So it's not about what you do, it's about something you stick with. I consider exercise like brushing my teeth. I do it twice a day. You do, some people brush maybe more often, but I consider that it's my regular thing which my body needs. As my teeth needs toothbrush, my body needs exercise. So I'll try to get one definitely in the morning and another one in the evening. So I think this is something, this is something what you need to do. Just find something you love, maybe do it with someone else, so you kind of enjoying together, and try to stick with it. And I think, sort of something about motivation, and Matt mentioned about motivation. Sometimes it's really tough, but just say to yourself, I'm just gonna go for a 5-minute walk, or I'm just gonna go to the gym. I'm just gonna walk through the door and have 5 minutes, and you'll actually find that 5 minutes will go into 20 minutes. And just trying to, and at the beginning will be tough, but I think what is important to establish routine. So like we've heard from Matt sort of blocks himself like a Windows. Within a day, it's a appointment with himself to do the running. So the same thing you could do. Oh, no, I can't possibly do that lecture because I need to go for a run, of course, within reason. So I think that's really important message. So moving on, again, sort of on exercise side, I'm exhausted most of the time, probably approaching treatment. So someone obviously who's got progressed CLL. Should I try to exercise, and how? I have never been particularly fit. I would say yes. I always say yes to the patient, just do it. Sorry, I'm sounding like a Nike advert, but it is just do it. I don't know, Ralph, and David, what your thoughts?
I totally agree. And I think it doesn't have to be exercise, because when we say exercise, people immediately think they need to go to the gym, sign up to a membership, buy Lycra clothes and do things like that. Just walking. Indeed, as you said, Renata, go out the door, walk. Even if you just walk to the corner of your street and then walk back, because that is enough for you, that is already exercise. And if one day you walk to the corner, the next day, try to walk to the next street. So physical activity, especially if you're starting off and you feel like you're very unfit, can work. Or walking up the stairs. walking up and down the stairs, that counts as doing some exercise or some physical activity and can be a starting point for something that, who knows, you might end up like Matt, running marathons.
So for those people who the disease starts to progress, obviously things change. Hemoglobin goes down, platelets change, iron levels change, and so biologically you're probably less capable of doing physical activity. And so it doesn't even have to be walking. Like you did with your chemo patient this morning, Ralph, it could be just sitting in a chair, standing up and then sitting down, standing up and then sitting down. Get a bag full of cans out of your cupboard and doing some lifts, arm lifts, just to get the heart rate a little bit higher, get the muscles working, and not necessarily be completely out of breath, but just to be able to do something, and just do a little bit more every time you possibly can.
Yeah, or even sort of, translate that to little, tidying your house, maybe some vacuuming, maybe a little bit of a gardening, just be out and do something. So it doesn't have to be something really strenuous. There's a very interesting question from someone who's 84 on ibrutinib and asks question, can exercise be dangerous? So for the last 6 months, I'm concerned about atrial fibrillation. Could exercise trigger this? So we know that people on ibrutinib has got 2 to 3% risk of atrial fibrillation. So that's a very well-known fact. We also know that very fit individuals, and we've heard of footballers sort of during the big matches, they may have exercise-induced atrial fibrillation. I think connecting these two, it's almost impossible to answer here that question, because the life is full of risks. I mean, we're constantly taking risk by getting out of the house, crossing the street. So yes, so if you take ibrutinib, you're taking on the risk of potentially developing atrial fibrillation, but there are mitigating circumstances. So the things I tell my patient, if you feel any palpitations or feel dizzy, I need to know about it. So I ask them to self-report. Also with ibrutinib, with cardiovascular complications, it's important to measure your own blood pressure. So all my patients, I tell them to get sphygmanometer, so they get into routine measuring blood pressure on daily basis, and that blood pressure needs to be treated almost straight away. We have at the CLL forum, we have published cardiovascular complications, so you can find that on British Society for Hematology, and there is a little leaflet come with it for the GPs as well, which obviously you can have a look yourself. So yes, so there is a risk with ibrutinib. There is of course risk with exercise and atrial fibrillation, but the atrial fibrillation with exercise, usually it's in a very young males with endurance treatment. So I think, I wouldn't say, for anyone, please don't do exercise because you might have an atrial fibrillation. I mean, yes, risk is there. And I think just it's important to mitigate risk. And, the atrial fibrillation is a manageable condition. You don't need to be taken off ibrutinib straight away unless we can't control the rate, how fast your heart is going. So I would say, doing exercise in your situation, when you're 84, you're on ibrutinib, I would say keep moving, because that exercise, it's the benefits of exercise hugely outweigh the problems. David, Ralph, would you like to add to that?
Yeah, if I can kick off, I definitely agree with that, Renata. And with this and with everything related to exercise, the most important thing is to listen to your body. If you feel like you're pushing yourself too hard, so we use this rate of perceived exertion scale that David mentioned a lot. As soon as you start feeling, oh, my exercise is going into the 8, 9, 10 area, you're working out too hard. And the same thing when you're exercising and you feel your heart beating really fast going into that atrial fibrillation, tell someone, stop, listen to your body. And often it then stops again, or if it doesn't, well, we can look into what's happening. But definitely, even if there is a risk, again, if you're doing it with exercise specialists who know how to deal with the situation, they can handle it with you if it occurs, but definitely do not use that as a reason not to do any exercise. But I'm sure David has an opinion on this as well.
No different than yours, Ralph. I think you and Renata answered that really comprehensively. That's brilliant. It's exactly, we have cardiac rehab for people who have AFib and different myocardial issues. So exercise is a huge benefit for people with heart transplants, never mind just heart attacks or AFib. So, like you say, Renata, the benefits outweigh the risk by millions. So yeah, just be careful.
Yeah, and I would emphasize that, the good old-fashioned mantra, no pain, no gain, does not count here. So if you've got pain, please stop, okay, and think why you've got that pain. And the exercise is not about how hard you push yourself. It's about consistency and doing it as your usual daily routine. So before, just one more exercise, and I'm very conscious that I've got nutrition team who are eager to answer your questions. So just before we move there, so that's a question from somebody in early 50s. I was very fit before being diagnosed with CLL, having chemotherapy treatment 4 years ago. I'm finding difficult to get back to anywhere near my previous level of fitness. Do you think the treatment could have permanently damaged me in some way? I'm willing to try anything. So I don't know, David or Ralph.
So we know that chemotherapy affects muscle biology, and it quite often causes damage that we don't know how long persists. It may be permanent, it might not be, but a lot of the damage from chemo can actually occur in the heart, and so that's why this risk of cardiotoxicity is increased with most patients who go through chemo. And so if the damage is there and it's permanent, then your level of fitness is probably never going to get to the same, but you're still going to be able to exercise and you're still going to be able to get fitter. It's probably just never going to be to the same extent. And it's a really interesting topic about chemotherapy and cardiotoxicity and muscle toxicity, because there's a lot of research going on just now. There's a lot of clinical trials going on just now, especially in America and Australia, looking at exercise during chemotherapy to try and offset some of these damaging effects of the chemotherapy on muscle.
Yeah. Ralph, anything to add to that?
Again, I totally agree with David, but especially with people who were very fit before treatment, it can be really difficult to get back into the swing of things. And what I always recommend is don't compare yourself to what you were able to do before you got diagnosed, because you'll probably never reach that point again, but compare yourself from where you are now to when you start doing exercise to where you are in a month, and look at that progression. And apart from that, as we age, our performance starts going down anyway as well. So there will always be a natural decline with it, but especially for the people who were very fit before diagnosis, try not to compare yourself to what you could do then, but just look at the progress you can make once you start going back in more physical activity and exercise.
Yeah, thank you. I think that's very important. Comparing yourself to your next door neighbor either, it's not healthy. I think you're right. Just capture what you are now and move forward, move on. Okay, let's move to nutrition. So the question to Long, Caitlin, and Barbara. So there is so much conflicting advice about nutrition. How can I tell what is worthwhile and what's just nonsense? It seems to change constantly. And it was actually quite interesting, if I just could throw a comment, when there was, just before we started, we had a survey, and most of you connected to this call, obviously very committed, well-informed CLL patients, and you think, I think it was something like 75-80% of you think you eat well, probably was even more. It's great, but I've got to say, I think what is important always to revisit and re-examine what you eat, because what you think it's healthy, as that question says, well, might not be a healthy advice. So Caitlin, Long, and Barbara, tell us, what is current advice about low carb, high fat?
Right, shall I make a start then?
Yes.
I think in terms of the where you find these resources, I think it depends on what the resources are. So if you get this information from like websites that's, I don't know, from the general media, probably you need to put a question mark of where they get this information from, because the actual evidence is more important of where they made these recommendations. So, for example, if you look at the NHS website, the information probably is more reliable than the information from, I don't know, the Sun, the website from the Sun. So I think the first is to question the sources you get it from, and where, and then if the information is based on a piece of research study, and what the quality is for that piece of research study as well. And if you don't, because it will be very difficult for you if you don't have that scientific background, then I think definitely go to those websites, NHS website, British Dietetics Association, and those credible websites for your information as a start will be very good. Caitlin, do you want to add anything there?
Yeah, I think it's a really good question. There's just increasing information about diet, isn't there? And it's very confusing. So as Long said, I think checking the source is really important. And actually quite a lot of reputable kind of cancer charities like Macmillan have really, really good information available. And also health professionals who are qualified to give advice as well. So dietitians, for example, some nutritionists are accredited, although it's not a protected title, but there are nutritionists who could give advice as well. And I think just thinking about, if you're looking on a website, for example, is that website trying to sell a product? And if so, then you need to be mindful that perhaps the information that's being portrayed is being done so to make that product sound appealing, rather than basing it on particular health claims as well. And I think if really, as a dietitian, and Long, I'm sure would agree, if there are still things that you're unsure about, then I would try and seek advice from a dietitian. I think, as far as I'm aware, most haematology services probably do have some access to a dietitian. So it would be really beneficial to talk to them if possible.
Yeah, I mean, I agree with Caitlin and Long in terms of the websites to look at. And I think that the British Nutrition Foundation have a really good website that's a very balanced view. And also SACN, S-A-C-N, the Scientific Advisory Committee on Nutrition, they produce reports, and those reports are very well researched. They have a whole team of experts, and they present the scientific evidence in the reports. So it's not just looking at a single paper, but they really try to look at the balance of evidence, and they give it, like, whether it's moderate evidence, high evidence, or poor, and so on. So you can get a balanced view from there. And the other thing is, just really bear in mind when you see the headlines in the newspaper, they're out to get sensationalism. They want to say something like butter is back, and it really gets the headlines. That was some years ago. And really it's about a balanced diet. And one of the dietitians at Surrey once said to me, we're really boring because we just say have a balanced diet. And that's kind of where we come down to. So we wouldn't recommend a low fat diet or a low carb diet. Everything is in moderation and balance, because you're going to miss out things. You really need fiber in your diet, and if you go on a low carb diet, if you're scared of eating carbs, then that's going to affect your gut bacteria, your gut function, and so on. So it's really about having a balanced diet.
On the sort of a sub question to that is another one. I'm confused about the difference between supplements and alternative treatment. Could you please explain the difference?
Well, supplementation is when you're deliberately supplementing a certain things. For example, with a vitamin D tablet or capsules for fish oils. I think maybe for alternative treatment, I'm not quite qualified to say it, so I might pass that on to Caitlin and Long actually.
So my understanding is that an alternative treatment or an alternative diet would be something that's used as an alternative to conventional treatment. And that's really where the difference is. So supplementation may be just something that's recommended by your medical team or your dietitian, whereas an alternative diet might be something that you undertake rather than having conventional treatment for a condition. And that again is slightly different to a complementary diet or complementary treatment, which is something that you may undertake in addition to conventional treatment like chemotherapy, for example. Long or Renata, I don't know whether you want to add anything about complementary and alternative treatments.
Not the definition of them, I think you explained really well, but I would like to say if you do go on or take any supplements, or if you do any alternative treatment, you need to let your medical team know or your MDT team know, because some of the supplements can interfere with the treatment. So I think your oncologist or your healthcare team should really know if you are taking any of the supplements, especially the ones that's not well researched, really.
Yeah, and I think that's so important. Thank you for that, Long, because especially with ibrutinib and venetoclax, the way they metabolize, they use the special enzymes in the liver. And there are obviously, you've heard anyone who's been on ibrutinib or venetoclax, you've been told avoid grapefruit, avoid Seville oranges or carambola, which is a star fruit. But there will be loads of others, not so innocent, which may affect the medication I'm prescribing. So I usually quiz the patient, and sometimes they coming up with a mile-long list of supplementations. And as you just said, I think the question is, how much do you pay for it? Because if it's cheap-ish, then fine, and it's your choice, as long as it does not interact with the medication I'm prescribing. So that's first. Secondly, all those health supplements, all those healthy gimmicks are sold for profit, usually. And there is not much evidence. The beauty of conventional medicine, because we are evidence-based medicine, and whatever we prescribe, I need to have a proper evidence with proper statistical analysis to prescribe it. Whereas Joe Bloggs out there on the street, they just sell it, because it helped me. That's an anecdotal evidence. That doesn't mean anything. So I think with the health supplementations and alternative treatment, it's your choice at the end of the day. But I would like you to discuss with your clinician, and I think that's obviously very important. There was a question about cholesterol and a diet. Anybody want to take that one on?
So our expert on cholesterol is a few doors away from me, and he's not on the panel. But there are certain diets that are good for lowering cholesterol, and one of them is the DASH diet, which is fresh fruit, vegetable diet.
Yeah, I think first of all, I think there's in the media they always say you need to avoid, or you need to have a low-fat diet to tackle your high cholesterol levels. But I think people need to think that when you go on a low-fat diet and your overall nutritional requirement is still the same, and then many people actually replace the fats they've reduced with refined carbohydrates, so like high sugar foods, which is equally not good. So I think, as Barbara said, the DASH diet or the Mediterranean diet is actually high in unsaturated fat, and that is actually a better diet compared to a diet that's high in carbohydrates, especially refined carbohydrate, and high in saturated fat. So you need to really look at the overall quality of the diet, and also in terms of the cholesterol. We know that a high fiber diet can also help reduce the the cholesterol levels as well. So it's not just about a certain element, but the overall quality of the diet. And anything you want to add there, Caitlin?
It almost comes back to balance again, doesn't it? Like Barbara was saying earlier, and I would just reiterate what Long has said, that actually it's thinking about the quality of the diet and that focus on where your fats are coming from, for example. So unsaturated sources like olive oil and nuts, seeds, oily fish, rather than the very saturated options.
Kind of taking on that, there was a question: are there any particular nutritional recommendation for coping with CLL? So of course, we all heard stories of people with brain cancer going on to dramatic and cutting sugar intake to absolute minimum. As far as I know, there is, I checked that there is nothing like that in hematological cancers. Obviously, people tried that in other breast cancer, for instance. I mean, what's your thoughts about that?
I agree with you, Renata. I'm not aware of any very radical diet advice that we would give. I've worked with hematology patients for about 5 or 6 years now. And again, I would just be recommending for people who are able to or are not struggling with their eating, just following a healthy, balanced diet. And then there might need to be some tweaks to that for people who are struggling. Particularly if you're on treatment, for example, and having side effects or struggling with appetite, then we would sometimes change people's approach to eating. So we would very much go for kind of a little and often approach rather than 3 meals a day, and really focusing on high energy and high protein where possible. But unfortunately, there isn't anything particularly prescriptive for CLL in particular.
So yeah, there's a question: is vegetarian or vegan diet good?
I don't think there's anything wrong with a vegetarian or a vegan diet, so long as you can get everything you need still. Yeah. And Long, please do jump in if you want to. But I think we know that sometimes people on vegetarian and vegan diets, perhaps maybe not so much now, but protein has always been a worry sometimes in the past. But I think actually there are very, very good, strong protein sources for vegetarians and vegans now. So as long as you're getting all your micronutrients that you need, and some of those like vitamin B12 are a bit more difficult to find if you don't eat meat. But I think as long as you've still got that overall balance, they are absolutely fine. Long, would you agree with that?
Yeah, and the Vegan Society has also produced the Eat Well guide for vegan and vegetarians. So, and to be able to enable to be on a balanced diet. And I think one thing you need to bear in mind is different CLL patients, they are different as well. And one thing we really need to avoid is also undernutrition. And that's where Caitlin explained of, don't avoid much food, or as a result of your treatment, you probably start to like side effects, you start to eat less. And if that's the case, then that we need to pay attention to that as well. So because we certainly don't want you to be malnourished, and that's where you need to access a dietitian as well.
Yeah, thank you. So there is a question back to exercise. I think that's quite a useful, practical question. If exercise is the best way of avoiding fatigue in the evening, what is the best to wind down afterwards to sleep well? Also, is it a good idea from the sleep point of view? So Ralph and David.
I'm not sure how to answer that one. So the question was, exercise to reduce fatigue in the evening, and then how do you wind down afterwards?
Yeah, if exercise is the best way of avoiding fatigue in the evening, yes, because obviously we know that if you do exercise late at night, you're kind of getting overstimulated and may struggle with sleep. So I think the question is, how to kind of balance it out. How to balance it out.
Ralph, I don't know how to answer that one, mate.
That's a difficult one, indeed. As what Renata said, don't do anything if you're exercising in the evening, especially later on in the evening. If possible, don't do anything too intense, because that might indeed wind you up a bit, so you're wired and you can't go to sleep. So if you're doing exercise later on in the evening, maybe do a bit lower intensity, but also make sure you're doing a good cool down with some stretches maybe some relaxation exercises, some yoga type things to really calm you down, bring your heart rate back down as well. Just a general good cool down, which for most people is overlooked anyway. But that would be my recommendation, but it's a difficult question to answer.
Yes, I think you are probably the person who answered that question. I think you need to find your own medium. Certainly don't do any strenuous exercise close to bedtime. And I think, like Ralph said, sort of do, you can find loads of meditation things, just kind of zone out. Meditation is simply just zone out and just be with yourself. It's very difficult to be with yourself and trying to cope with that. But that's what meditation is about. If you can do that for 12 minutes, that's really beneficial. The question we've got still, and I realize Barbara needs to shoot off, a question about, could you explain a bit more about lipid connection and omega-3 supplementation?
Yeah, I can take that quickly before I have to leave.
Thank you, Barbara. Sorry, I appreciate your time.
That's okay. So omega-3 fatty acids, especially the longer chain omega-3 fatty acids, because there's a shorter chain one, which is found in oils. This is called alpha-linolenic acid. That's got 18 carbons long. We also have the ones that are found in fish. So they're a little bit more potent, the ones in fish. But they reduce triglyceride concentrations in the blood. So they do this through the liver. So that's how they work. And they also reduce inflammation. So in general, that's a feature of them.
Yeah.
Is that enough?
Caitlin Long, do you want to add anything to that? I mean, one thing for me, I've got to say, and I'm allegedly, I'm a healthcare provider, not allegedly, well, I am. And I've got to say, when I try to find a good supply of omega-3s, it's a mind-blowing down there, because obviously it can be, well, A, they're expensive, B, they may just go off and it's not the right concentration of EMA, EPMA, etc. It's truly science. So basically what I do, I just eat loads of fish. Because I thought that's probably just let's cut the middleman. Let's just go for source.
Yes. I mean, the evidence is better for fish. But, the recommendation of eating 2 portions of oily fish a week. But if you do want to buy them, if you do need to buy them, and then yes, I agree. So you have to look at the label, because if you buy, for example, cod liver oil, the concentration is not high. There's actually more saturated fats in cod liver oil than there are long chain fatty acids, because it is just a small percentage. So yeah, you do have to look, and there are some algal sources of omega-3 fatty acids now, because fish, they don't make those omega-3 fatty acids themselves. They get it from algae. So instead of getting the fish, if you're vegetarian, for example, you don't eat fish, then you can go further downstream to the actual algae.
Yeah, thank you. Another quick question. I realize we probably passed the time, but I think there are so many questions. So there is another question for Ralph and David from Victor. David has spoken about dedicated exercise. How can, quote, manual work type exercise be considered?
Ralph's had to leave. He's got to go teach it at 2:30, so I'll answer that one. Yeah, manual labor work is still considered physical activity, and so you have to account for your manual work when you're talking about your physical activity levels. I actually got into exercise in CLL because one of the patients at Duke was chopping down trees. And he was telling us that he was getting fitter, and his CLL cell counts were not going up, and they were just maintaining. And he put it all down to the fact that he was a lumberjack, and he was out in the forest all day long chopping down trees. And so manual labor is definitely a component of physical activity. What you have to be aware of with manual labor though is that there's a skewing towards what a lot of manual laborers eat, and so quite often it's not as healthy as what happens if you're doing exercise or you're specifically going out to do physical activity. So you have to be careful with the balance of diet with your job.
Yeah, thank you. And another, maybe last question for Long and Caitlin. I have had CLL for 6 years. I'm still on watch and wait. I'm overweight. I would desperately like to lose weight, but I have binge eating disorder. Any advice?
I think I saw that question. I think first of all, I would like to ask, is the binge eating disorder diagnosed by the healthcare professional? Because it is the bulimia is a mental health disorder, and that needs to be diagnosed by the healthcare professionals, and also depends on the symptoms you have. If you are diagnosed, then I think we need to address the bulimia first by having the multidisciplinary care team involved. So we need to address that first before we're moving on to weight loss, really.
I would agree. I think that needs a team approach and probably some kind of psychological, maybe CBT treatment in addition to dietary advice, because it's all very well and good a dietitian coming in and saying do X, Y, and Z, but if there are some behavioural issues with eating in terms of the binge eating disorder, then it's just as important to address them as well. So I would encourage this individual to seek a referral to a dietitian and speak to their team about it as well. Yeah,
I absolutely agree. I think sort of sometimes binge eating and food addiction, I know that there is loads of controversy about food addiction, but I think, in my personal opinion, I feel food addiction should be treated as any other addiction. So, so obviously 12-step program and all, so we need to look and, try to find a professional to help you, because that's a tough one. I think because we overrunning, so just a handful of questions which I thought it would be quite important to there's just one for maybe Long and Caitlin. Is the connection between genetics and nutrition? So do people use calories in different ways? That's a topic to discuss. Write an essay for 10,000 words, but try to answer that. It's fairly short.
I think it's an excellent question, actually, and I think personally, I think that's the sort of the future of dietetics, like personalized nutrition. At the moment, the evidence, so the research is still ongoing, and we don't have enough research evidence to support. We have some very strong evidence in certain conditions, such as PKU, where the diet absolutely play an important role. But in terms of CLL, we are still, we're still a long way to go to find, if a certain genetics of people respond to the use of calories or even the use of fatty acids or carbohydrates differently. Personally, I think probably in the future we might find evidence for that. At the moment, we don't. We probably have some people maybe more prone to the benefits of exercise as well, because we did find that in certain type 2 diabetes patients. But again, as I said, the evidence is not enough, and hopefully in the future we will have more research findings on that.
Can I just quickly add to that one? So
yeah,
you're right. That is it's a fantastic question. And in the exercise world, we're now looking at prescribing exercise to different cancers on their mutation status rather than on the cancer that they're receiving. And so Lee Jones over at Memorial in New York, he has a program where whatever your mutation is, you go into this exercise program, regardless of what your cancer is. And it could well be that's you're right, that's the future. And we start stratifying these kind of studies that we're designing on what chromosomal deletion our CLL participants have, rather than how old they are or how long they've had the disease. This is the genetic aberration. What is it doing to their physiology and to their health outputs?
Yeah, but I mean, don't go out there and don't check your genome just yet. We're not. It's a huge amount of money, and we are not ready for. The medicine is not ready for that. I mean, obviously, we need David's research to answer those questions. So a couple more. So I'm on a treatment, venetoclax, and I just don't feel hungry. I'm sure my nutrition is not very good. What should I do? Should I be taking vitamin tablets, for example? So we know that loss of appetite is one of the venetoclax side effects. So this is not an unusual. I don't know, if that's a side effect of a medication we prescribe. What would you say, Caitlin or Long?
I think I've seen this quite a lot in venetoclax patients actually, and we would just be trying to give some really practical ideas. So for example, if you've got a big appetite, the idea of trying to have 3 meals a day can be very overwhelming. So as I briefly touched on earlier, we often say try and have smaller meals with more frequent snacks in between. And I think the word snacks kind of conjures the image of unhealthy options, but it's just having smaller meals, breaking it down over the day and trying to make use of all that time in the day to eat. And we would often also encourage kind of some higher calorie, higher protein options where possible, because you can eat less of them and still get the nutrition from them. So we would always try and say, if you can get your vitamins and minerals through your food, then that would be the ideal way to do it. But we do identify that actually that can be quite difficult for some people. So a vitamin and mineral supplement may be appropriate, but again, we normally wouldn't do that without discussion with the medical team, just to check that that's not contraindicated by any medications. Long, is there anything you want to add?
The only thing I can add is normally if you're under a GP, they should have a dietitian or dietetic team covers that GP practice. And if you experience issues such as malnutrition and weight loss, your GP can refer you to see a dietitian, because they will then discuss in more details of that's more appropriate to yourself. So would definitely do that to see a dietitian via your GP.
So I just really need to wrap up, and I'm so sorry I haven't answered all your questions. But essentially, this is a beginning of a long journey. Actually, myself as a chair of UK CLL Forum, I'm trying to set up together with CLL Support Association a move for sort of living well, because obviously loads of you, as you said, I'm on active monitoring, watch and wait, or I've just finished treatment. So there's loads of you who want to get better, and that's what we're trying to do together. So there will be more information, more little things coming on CLL Support Association. So watch this space, and obviously David will be running his trial, and I'm sure we can bring David sort of back maybe once the trial starts recruiting to tell you a little bit more what's been happening. So thank you, the panel. Thank you, David, for bringing such a fantastic team. Thank you, Ralph, Barbara, who unfortunately had to leave, and Caitlin and Long to join.